Hello everyone. Lastly, we spoke about atrial enlargement, and now we move on to the hypertrophy. So, hypertrophy is a term that we particularly use when it comes down to ventricles, and because ventricles are muscular, they undergo muscle hypertrophy more than the enlargement. When we correspond to the LV hypertrophy, the left ventricle can undergo either pressure overload or volume overload. So, whenever there's some overload, the LV muscle mass also increases. There's pressure overload, the muscle mass increases, but the size of the ventricular cavity remains the same. But when there's volume overload, the muscle mass as well as the internal volume of the left ventricle increases. Okay, so that is why we call it left ventricular hypertrophy. The thing with the ECG is not the most sensitive measure to confirm LV hypertrophy. It's not better than echo for sure, and echo is what we would consider gold standard, or perhaps the new modalities like MRI, CT, that can also be considered as gold standard. So as I spoke about it, it's got very limited sensitivity. The ECG has got very limited sensitivity, but there are at least thousands of criterias, and in which I've come with the best ones, where we're gonna talk about LVH and its effect on ECG, as well as what are some of the abnormalities that you must know. So without further ado, let's just jump on to describing the ECG criteria of LVH. And we're going to start with QRS, because that's where you most importantly see LVH. We're also going to talk about P wave and the ST and the T segment. So let's understand the first very much criteria, which is based on the QRS, right? So in QRS, as I've mentioned, the first criteria is S in V1 and S in V2 is going to be more than 30 mm. So let me just quickly draw how the ECG in the V1 is going to look like. So this is how V1 will look. And as I mentioned in the previous one, along with the LVH, there's going to be left atrial enlargement. So that's why you're going to have biphasic or inverted T waves in lead V1. And this is what I mean by deep S wave. And the amplitude of this wave is going to be more than 30 mm or 3 large boxes. So that is our first criteria to define presence of LVH in ECG. Now what happens in the lateral leads, which are V5 and V6, the lateral chest leads. So in the lateral leads, let's say I'm drawing V5. So again, this is your M mitral because of left atrial enlargement. In the lead 5, you're gonna have very tall QRS. Either this is going to be like this, or similarly you're gonna have this. So let's just assume this is the ECG in lead V5, and this is going to be a P wave, QRS and T wave. So the amplitude of R wave in either V5 or V6 is again more than 30. So it's easy to remember criteria. It's the same one with the right-sided leads and the most left-sided leads. The right-sided leads are going to show you deep S wave, and the left-sided leads are going to show you tall R waves. And the measurement of the amplitude is going to be more than 30 mm in both. Now we move on to the third criteria, which is the most famous one and everyone knows about it. This is when the addition of the V1, the S in the V1 and the R in the V5 or V6. Let's say this is V6. So the R in V6 and their addition is going to be more than 35 mm. And this is what is your famously known as Sokolow-Lyon criteria. So this is one of the component of Sokolow-Lyon criteria, where we talk about SV1 plus the addition of the RV5 and RV6 to be more than 35 mm. Similarly, this is going to be the second part of the Sokolow-Lyon criteria. So Sokolow-Lyon criteria again has two components, the SV1 plus RV5 and R in the AVL. The AVL is going to be the lateral most lead. So these are like brother to V5 and V6. And similarly in these leads, the R amplitude is going to be more than 11 mm. And as far as from my experience, this is one of the most commonly observed finding in ECG, where I would just look at AVL and I would know that the patient has LVH. So this is another component of Sokolow-Lyon criteria, where R in the AVL is going to be more than 11 mm. So the important ones that I've already discussed are going to be there: S in V1, R in V5, SV1 plus RV5, which is your Sokolow-Lyon criteria, and R in AVL. Now let's just quickly jump on to other criterias where in the limb leads, which are your 2, 3 AVF, 1 AVL and AVR, you are going to have either tall R or the deep S. So in the lateral leads, let's say for example AVL or lead 1, if you get very tall R which is more than 20, that's also one of the criterias. And the deep S wave, let's say on the right side lead, for example your AVR that shows your deep S of more than 20, that is also going to be an example of LVH. Again, the voltage criteria, if you measure the voltage, the amplitude of all the 12 leads and their addition is more than 175, 175 is the maximum limit given for normal amplitude measurement, and if it's more than 175, then we are very well to call it LVH. Moving on to the concept of VAT and intrinsic deflection, I'll quickly run through VAT and intrinsic deflection in the next one. While the QRS widening as well. So whenever there's going to be LVH, as I mentioned, there's going to be left axis deviation as well, and the left axis deviation, so it's gonna go more than minus 30, and that is also one of the diagnostic criteria for LVH. Now we move on to some of the named famous criteria for LVH. The very famous one that we already discussed is Sokolow-Lyon criteria, which is SV1 plus RV5 or RV6 more than 35, or R in AVL of more than 11. Now we move on to the Cornell voltage criteria. So it's one of the criteria in which you are using, this is your limb lead and V3 being your chest lead, the combination of the two, right? So R in the AVL plus your SV3, which is going to be chest lead, if it's more than 28 mm in males and more than 20 in females, that is when you call it Cornell voltage criteria. And just remember, it has both limb leads and chest leads, and V3 and AVL are not exactly the opposite leads. One is in the lateral direction, one is most anteriorly, but still the criteria applies, and because the LV grows in lateral and anterior direction. So next is Cornell product. So Cornell product is simply whatever Cornell voltage criteria we've added. For example, let's take an example where this is the criteria and we got a value of 28, and you have to measure the QRS duration. So QRS duration, let's take the maximum QRS duration, for example 90. So just multiply by these two, and if the product is going to be more than 2440, for example in this case it's going to be 28 into 9, it's my maths is very weak. It's going to be 280 minus 28, so 152 or 252 or something. Not sure if that's correct, but it's definitely more than 2440 milliseconds, and that's when you get the Cornell voltage criteria, which is finally called as Cornell product, where it is a multiplication factor between Cornell voltage and the QRS duration. Now let's move on to the last and the least famous one. It's called Romel and Estes criteria. When the Romel and Estes criteria, the components are too much and we don't use it. It's just for the theoretical sake. Just remember that there is three components, mostly QRS widening, there's left axis deviation, and all the most of the QRS criteria that we have explained before are part of the Romel and Estes criteria, where they have been assigned different values. For example, this is a assigned value of 2, this is assigned value of 3, and if the total is more than 5 or equal to 5, then we say that the patient has LVH. Now that we've covered QRS criteria, let's just quickly jump on to the P criteria. So P wave is basically because of your left atrial enlargement, and if the LA enlargement is there, you're gonna have either the M mitral, inverted P wave in V1, or biphasic V1 in V1, where this is going to be more than 1 mm. Right, now let's move on quickly to what happens to ST segment in LVH. So as we discussed, the QRS, the R is very deep in in LVH because of the prolonged ventricular depolarization. The ST segment might get depressed, and so the T wave. So this is ST segment, ST T wave, and this together is called as strain pattern. It's very common in pressure overload condition, and this is what we call a strain pattern. And this you will see mostly in the lateral leads, which are V5 and V6, because they are going to have most of the R wave amplitude as compared to the most of the other leads. So let's understand the concept of VAT, which is ventricular activation time. So this is the time taken by the impulse to reach the recording electrode. So whatever chest electrode is there, let's say I'm recording in the V3 here. The time from where the endomyocardium gets depolarized to the epicardium to this, suppose this is a chest wall, to the lead. This is represented by ventricular activation time. And what happens in LVH is the VAT is slightly prolonged because the QRS widens, and it is measured from the start of the Q to the peak of R. So for example, QR segment only you can call ventricular activation time. Since the ventricular activation time is prolonged, the intrinsicoid deflection, that is when the ventricle is depolarized and starting to repolarize, which is represented from this downward deflection. This downward deflection is also, it's called as intrinsicoid deflection. So the time when the intrinsicoid deflection occurs is also prolonged. Since the VAT is prolonged, intrinsicoid deflection is also more than 0.05 seconds. So the last and the final, you have pressure and volume overload. So the pressure overload conditions are like your hypertension, which is the most common pressure overload condition, and most of the times you are going to see this in the ECG. Hypertension, hypertrophic osteotic cardiomyopathy, aortic stenosis, and even coarctation of aorta. These are the conditions where you're going to have pressure overload. Volume overload is when there's a patient, let's say someone with aortic regurgitation, mitral regurgitation, PDA, even in high output states like thyrotoxicosis, anemia, you're going to have volume overload condition. So let's quickly understand what happens in the ECG when these two conditions are present. So in the pressure overload, there's hardly any Q wave, and also the ST and T segment are depressed, which is also called as your strain pattern. While in the volume overload, and this is most prominent in V5, V6, as I mentioned, the lateral leads. Also in the volume overload states, what happens is you have deep Q waves and tall and peaked T waves. So that's the difference between volume and pressure overload condition. So ECG can tell you a lot. Even just by looking at the ECG, you can tell whether the patient has just hypertension or patient has other volume overload states. Thank you so much for watching, and stay tuned to learn about the most important right ventricular hypertrophy and what are the criteria for the same. And do check out atrial enlargement videos and to give me your valuable feedback.